So for our next speaker, I'd like to introduce one of my colleagues from Cardiff, Dr. Dan Smith, who works in the laboratory attached to the Wales Kidney Research Unit. And one of his interests is answering one of the why questions about IgA nephropathy, and why in some people the disease remains fairly stable and in others your kidney disease declines quite quickly. So I'm really happy he's given up his time to speak to us today, and thank you, Dan.
Okay, I'm quite loud anyway, so I probably won't need this, but thanks to Sian, first of all, for inviting me to come down and speak to you guys. I will say, I used to have imposter syndrome when I gave talks to patients and stuff, because I did my PhD in chemistry, and all of this is very clinical in biology, but imposter syndrome times 10 to be in front of the god that is John in IgA nephropathy, having only really got into this field about a year and a half ago. So if I say anything wrong, he's probably going to shake his head at the back there, but just bear with me. So yeah, I want to talk a bit about reading the pea leaves. So how we can use urine samples to try and determine how your IgA nephropathy is going to progress, or not progress, which is obviously the ideal situation. So John sort of covered this at the start, so I won't labor too much to the point, but it is, IgA nephropathy is the most common form of glomerulonephritis, affecting mostly younger adults, but as we know, it can sort of get you at any age. It just affects around people with around 30% of the people with IgA, and will then go on to kidney failure. So about a third of them, and no current biomarkers can currently predict that IgA progression. It's all based on years of monitoring EGFR and creatinine and so on. My specialty, and the reason why I'm here, is I work on things called microRNAs. So I think everyone in here would be able to give me a good description of what DNA is. DNA is essentially is a very it's a duplex strand of code, essentially, that tells your cells what they are and codes for you. DNA itself is what we call transcribed and translated, which basically means it's unwound and decoded into RNA. RNA then tells your body what proteins to make. Whereas microRNAs are very, very small forms of these. They're around 19 to 23 of those little letters that we talk about. DNA is millions and millions of those letters. And what these do is they regulate the expression of those proteins and those genes. So essentially they are there to switch on some proteins or switch off other ones and keep your body going as it should do. However, in various diseases, we do know that these microRNAs can change. So sometimes they will go up, sometimes they will go down in response to a disease, particularly in kidney diseases such as AKI, so acute kidney injury, diabetic kidney disease, delayed graft function following transplant, and obviously the reason why I'm here, IgA nephropathy as well. And I should mention John's group here. So recent biopsy analysis from people in John's group has highlighted me a 150 as a potential marker of IgA progression. I mention that specifically because I'll be coming onto it in my work in a second. So again, I don't need to label what IgA is. I think we all know what it is. It's a current because of the immunoglobulin that basically just forms around the glomerular tubules, causes blockages, and causes the kidney to become damaged and leaky. But microRNAs, which you might not have heard of, so microRNAs, as I say, they start with DNA, which is the code for your cell. These are then transcribed and translated and through various different processes until they form what's called messenger RNA. Messenger RNA is what then codes for the proteins the cell produces. MicroRNAs are small versions of these that bind to that messenger RNA and basically prevent the reading of that messenger RNA. So the proteins aren't produced, therefore you don't get the protein that you should expect. And that happens down here at the bottom end of your cell cycle. Once that is used up and we no longer need the protein to be switched off, the microRNA is broken down and your body carries on as normal. Now we know that changes in microRNA expression are associated with cancers, cardiovascular diseases, and kidney diseases, as we've talked about. This gives them significant biomarker and diagnostic potential. It also indicates potential mechanisms of action, so it tells us sort of what is happening and where, which then helps us to obviously develop therapies in order to combat this. Now, RT-qPCR, so reverse transcription or real-time quantitative PCR, polymerase chain reaction, is the current gold standard for microRNA analysis. I'll talk about that in a second. But we, as I said, have found various microRNA expression patterns for various kidney diseases within our group. So diabetic kidney disease is our sort of specialty area in Cardiff, but we also look at bacterial peritonitis and have found various expression differences in people with a bacterial infection if they are having peritoneal dialysis, and delayed graft function as well. So people who have a transplant and then their transplant doesn't sort of kick in for at least 14 days after the transplantation, we can monitor these microRNAs to see who is likely to have that reaction following a transplant. So that's our sort of work within the unit itself, in the World Kidney Research Unit. But what about us, and me specifically? So we know that IgA is predominantly diagnosed through biopsy, okay? It's kind of the best gold standard to diagnose it, but we don't know how that IgA is going to progress. And as John pointed out earlier, everyone is different. Some people will go on and have essentially no reduction in their kidney function. Some people will massively decline. The problem is, and particularly as we alluded to earlier, where we're trying to develop new drugs to prevent this, is the only way to find out is to monitor a patient for 20, 25, 30 years to see how that patient progresses. Now, in pharmaceuticals, that's not good enough. We need to know, is the treatment going to work 20 years from now, but we need to know it within 6 to 9 months. So we are always trying to develop a way to sort of get into that transition, so we know who is going to progress in 20 years versus who is going to stay where they are. And ideally, we can use a marker then, the same marker that tells us which patient is going to progress versus which aren't. Hopefully that marker will also tell us if the medication that we are giving to the person, so say we give them the medication over 6 months, does that marker then change? So they were going to be progressive, but 6 months later, they've hit the point where it looks like they're going to be stable for 20 years plus. So it's a sort of instant readout onto whether or not that drug is functioning. So using the Nurture Biobank, so I will mention Nurture a bit because I currently work for them. So the National Unified Renal Translational Research Enterprise is a big biobank that essentially collects biopsy, urine and blood samples from many different patients across the UK, about 3,000 patients with CKD, many of which had IgA nephropathy. We have used their biobanked urine samples for this analysis in order to find these new biomarkers. So what I did is in initial discovery cohort, we take 20 people with what we call stable IgA nephropathy, which means that their EGFR following the point of, so they gave a urine sample. We looked at what happened to their EGFR in the 4 years following that. These are people who had an EGFR decline of less than 2 mils per min per year, so essentially they're flatlining. Versus 18 progressive people where that decline was more than 2 mils per min per year, so it's a rapid decline of their EGFR function. We do what's called a TACMAN low density array, which is a very fancy way essentially of saying that we've got 754 different PCR reactions that happen on that plate. Now, since COVID come along, I think everybody kind of knows what a PCR test is, but it's essentially a way of counting how many RNA molecules there are in a particular sample. So we can screen for 754 microRNAs across all of these 38 samples, gives us around 28,000 data points to look at. We can then find some certain targets from that particular subset of 754 microRNAs. We can look for them in a bigger cohort. So that's what we did. We looked at 61 stable versus 91 progressors, and then looked at standard benchtop RT-qPCR, so looking at it individually. Now what this does, this discovery cohort, it generates this thing that's called a volcano plot. Now this is a very complicated looking diagram, but the key thing to know is that those dots in the green in the top left-hand corner, every dot on here is a microRNA sequence. Okay, so 754 of them. The green dots in the top left-hand corner are microRNAs that went down. The red dots are microRNAs that go up in progression. We can then run essentially a stats test that says, okay, well, if we add each of these dots in individually, what combination gives us the most predictive power? And that highlighted these bottom right-hand corner microRNAs there, so 133A, B, 99H, and so on. We also threw in MIR150, which was came out in biopsy samples from the Barrett group in Leicester. So we decided to look at them in urine samples as well. And essentially, once we had this selection of A7 microRNAs there, we went forward into the bigger cohort to look at them again. This was the result. Don't worry too much about it. It's very data-driven. But essentially, the bar on the right is bigger than the bar on the left, i.e. the people who progressed had a more upregulated, so more of that microRNA than the people on the left. If there's stars, so 2 stars is very significant, 1 star is significant but not by a huge amount, and then NS means non-significant. Now, don't worry too much about it, but essentially all of these showed that there is that upregulation, but these particular 4 on the left shows the strongest correlation there. If we then look at this in terms of quartiles, so we separate out the people with the highest level of these microRNAs versus the lowest. So in quartile 1, that's people with the lowest microRNA expression. Quartile 4 is the highest. You can see you get that sort of linear response. So it is, it relating to their microRNA response, which then leads us to look at this statistically to say, okay, well, how powerful are these combinations? Now, these are what we call receiver-operated characteristic curves, or ROC curves. But the way to look at this is, if you see an AUC, so AUC is the area under the curve. If you have an AUC of 1, that is the most perfect biomarker in the world. That will tell you that you will never get a false positive, you will never get a false negative. That biomarker is 100% correct. The standard sort of biomarker across nephrology for looking at progression is what we call urine albumin-creatinine ratio. So it looks at, in your urine, what is the amount of albumin versus the amount of creatinine, and what's the ratio of that. And then we can relate that then to whether you're going to progress. Now, as John pointed out earlier, people in IgA, some of them have great creatinine, some of them don't, and it's a very sort of sporadic subset. So in IgA specifically, this is only accurate in about 69% of people, about 69.5%, which is obviously, if you've got 0.5 on here, it's a coin flip. It's either there or it's not. Looking at our best performing microRNA, which is MIR150, that is about the same, okay? No improvement. However, if we take the combination of microRNAs that we found before, plus the urine albumin-creatinine ratio that we use altogether, you get suddenly a set of markers that are 84% predictive ability. So you can see we've gone up by 15% worth of prediction there. Now, in clinical terms, the ideal AUC for a clinical test is 0.9, because obviously, we want it to be that recommended. 0.8 or above is good and warrants further investigation. Now, just to throw in, why we consider IgA a particularly difficult disease to prognose and look at progression. If we take a similar subset, which I did in diabetic kidney disease, I'll talk about that in a second. I'll come back to that. So if we look at a subset in diabetic kidney disease, you can see that the urine albumin creatinine ratio for diabetic kidney disease is about 0.842, so it's already 84% predictive. Our microRNAs that we found with diabetic kidney disease was a little bit better at 87. Again, combine those together, you get that 0.913, but that 0.84 is already pretty good. So for diabetics, we can already use the urine albumin creatinine ratio. And yeah, okay, we get improvement, but it's, compared to IgA is a lot worse at prognosing your progression from that urine albumin creatinine ratio. I have to go back. So what do we do now that we've found these markers? So ongoing work at the minute is to use an experiment called laser capture microdissection, which is basically where we take a biopsy and we cut out the glomeruli. So we take your biopsy sample, we look at it under a microscope, and we use a laser to cut out the glomeruli versus the tissue around it. And then we measure these microRNAs to find out, are they happening in the glomerulus, so at the site of the disease, or are they happening somewhere else that then causes the problem in the glomerulus? By localizing these microRNAs, we can then look at the mechanism that they are happening by and ultimately use them, for better markers for treatments that are coming out, as John mentioned, or to look at new treatments further along that stops that progression. And as I said, we did this in diabetic kidney disease. I don't need to go over that because that's not relevant to you guys. But essentially, it was a similar story, except that we already had a good marker. So comparing the two together, you can see at IgA, and sorry, it's a bit small, these graphs, but IgA is around 69% predictive in UACR compared to 84% in diabetics. So IgA is significantly harder to prognose. But using our combination of microRNAs that we found and the current gold standard, we've managed to get up to about 84% prediction. We're obviously looking to push this further to actually make it into a clinical test that we can then use to hopefully identify those people that are going to progress versus those that are going to stabilize, so we can give you a more personalized medication. So yeah, so that's me. Sorry, I just wanted to keep it brief because we are overrunning a bit, and you know, I didn't want to do too much sciencey stuff. I just want to thank obviously Sean for inviting me again, the Wales Kidney Research Unit, particularly their donation fund, because they are the people that, so we get donations given to us at the unit by altruistic people who then we use that to do the research, and it was that fund that helped me to do some of this research. And obviously the patients that donated to Nurture. Before I go, because as I say, I do work for Nurture now, so I work for Kidney Research UK, we are having a new Nurture Biobank. It would be wrong of me to not advertise it while I'm sat here. So our upcoming Nurture Biobank of Kidney Research UK is Nurture AKI, is to look at people who have an acute kidney injury and how these people will progress. Obviously, some people with IgA nephropathy will have an immediate decline as and are more susceptible to AKI, and therefore will also form part of this biobank. But I just wanted to highlight that. If anybody has any questions, you can feel free to ask me now, or I'll be around briefly at lunchtime, but my email's on these slides, and I'm happy to make them available to anybody who wants them. But yeah, any questions? I'm on time as well, look at that.
Maybe I'll start with one. So it's interesting to see that the profiles of these MERS was different between diabetic kidney disease and IgA nephropathy, which I thought was interesting because as a clinician we often think of a final common pathway that causes kidney disease to progress. So that's interesting, you've got different signatures. Do you have any clues as to which proteins or pathways are modulated by those two different populations?
Short answer, no. Long answer, so microRNAs are quite promiscuous. So they have, you might see MIR150, for example, in IgA, but then you might also see it in leukemia or something. They have various different effects throughout the body. We do know a lot of them are to do with cell apoptosis or cell death. We know a lot of them are to do with cell differentiation, converting one cell into another cell. I do have a table. It's quite a long table of what these particular microRNAs are targeting. That not many of them are particularly known. So MIR150, I think, is the most well known. I can't remember what it does off the top of my head, but a lot of them haven't been seen before. So they've been found, and obviously we know what they are, but they haven't sort of been related to their mechanism as yet, which is where we're looking to go. But in terms of the differences between them, you're quite right that in an ideal world we would have a marker that tells you whether you're going to progress regardless of what kidney disease you've got. That would be the best. If you've got IgA, if you've got diabetic kidney disease, if you've got physical injury, whatever it is, we would ideally have one marker that says, okay, we're going to progress or not progress. That is something. So obviously I've got diabetic kidney disease there. I've also got hypertensive nephropathy. I've also got some microRNA signatures from people who've had a transplant. We haven't combined them all together into one data set yet. It's kind of our future work to look at taking all of these microRNA signatures and saying, is there anything across them that might be useful? But we haven't done that yet.
And do you think there might in the future be the potential to use these to decide which of these new drugs might be the best for an individual person? So if you have one that suggests a pathway is activated, and you need to target, say, complement, which is something that causes inflammation, and in another patient, you've got something that's a signature of fibrosis, so you want to target that. Is that somewhere that this might go?
100%. So that's that. I mean, that's the ultimate long-term goal, is to use this either in therapeutics, so we can sort of simulate microRNAs to, turn them off, turn them on. So if we find that microRNA, for example, 150s goes up, which causes this problem, we can find ways to switch it off to stop that progression from happening. But as you say, the ideal world would be that we can take a person's urine sample, we can measure their microRNAs and go, okay, we know that this one particularly has gone up, and that is causing, as you say, inflammation. So we need to target the inflammation. That's what's causing your progression. So we can specifically say, yes, we will use that medication. As John said, there's 10, 12, we're going to have a cupboard full of them, but it's which one do we use? Yes, long term, we would like to be able to say, this is your microRNA signature, therefore you should use this drug. This is your microRNA signature, therefore you should use that drug, in a much more sort of personalized medicine approach.
That's great, thank you.
And how long is long term?
How long is long term? Well, I hate putting numbers on things, because we as scientists, we're very optimistic and say, oh yeah, we can do it next year. It's probably not going to be next year. I would imagine it's probably, so before I started doing this biomarker stuff, when I was a chemist, I was looking at urine dipsticks to measure these microRNAs, so you don't have to do the PCR. You can just sit in a clinic and they'll do a dipstick. I would say probably, I would like to see these being used in the next 5 years, but I mean, that's me being optimistic.